As neurologists, accurately localizing a stroke is essential for diagnosis and management. In this video, I'll take you through how to systematically localize strokes by understanding anterior and posterior circulation territories, paired with clinical examples and pearls to refine your skills. Let's get started. Internal carotid artery, ICA, stroke. ICA occlusion can cause a large hemispheric stroke involving both the MCA and ACA territories. Symptoms include contralateral hemiparesis, face, arm, and leg involvement, depending on collateral flow, global aphasia if the dominant hemisphere is affected, and ipsilateral monocular blindness, amaurosis fugax, due to retinal ischemia from ophthalmic artery involvement. Key exam clues. Look for a combination of cortical signs, e.g., aphasia, neglect, and subcortical deficits, e.g., hemiparesis. Pearl. A significant ICA stenosis or occlusion might not always cause symptoms due to collateral circulation via the circle of Willis. Use CTA or MRA to confirm. Middle cerebral artery, MCA, stroke. The MCA is the most common site of ischemic stroke. It supplies the lateral frontal, parietal, and temporal lobes, as well as the subcortical structures, e.g., basal ganglia via lenticulostriate arteries. Clinical features: contralateral hemiparesis and hemisensory loss, with face and arm more affected than the leg. Dominant hemisphere, usually left Broca's aphasia, if anterior division is involved, Wernicke's aphasia, if posterior division is involved, and global aphasia, if both divisions are affected. Non-dominant hemisphere, usually right hemi-neglect or constructional apraxia, and visual field deficit. Contralateral homonymous hemianopia, due to optic radiation involvement. Pearl. Lacunar infarcts in the lenticulostriate arteries, deep MCA branches, can cause pure motor or sensory strokes without cortical signs. Anterior cerebral artery, ACA, stroke. The ACA supplies the medial surface of the frontal and parietal lobes, including the leg motor and sensory cortices and the corpus callosum. Clinical features: contralateral leg weakness and sensory loss, more than face/arm, and behavioral and cognitive changes, such as abulia, lack of motivation, apathy, or personality changes, frontal lobe involvement. If bilateral ACA infarction occurs, akinetic mutism or severe apathy. Pearl. ACA infarcts are rare due to collateral circulation from the opposite ACA via the anterior communicating artery. Posterior cerebral artery, PCA, stroke. The PCA supplies the occipital lobes, inferior temporal lobes, thalamus, and midbrain. Clinical features: contralateral homonymous hemianopia, a hallmark feature due to occipital lobe involvement, visual agnosia or alexia without agraphia, if the left PCA affects the splenium of the corpus callosum, and thalamic syndromes. PCA strokes involving the thalamus, e.g., via paramedian arteries, can cause contralateral sensory loss and thalamic pain syndrome, Dejerine-Roussy. Pearl. Use diffusion-weighted MRI to confirm small PCA infarcts, especially if symptoms are subtle. Brainstem strokes. Brainstem strokes are often due to occlusion of the vertebral or basilar arteries, with symptoms depending on the level of the lesion. Key syndromes: midbrain, Weber syndrome, ipsilateral CN3 palsy, ptosis, dilated pupil, eye down and out, and contralateral hemiparesis, corticospinal tract involvement. Pons, locked-in syndrome, complete paralysis except for vertical eye movements, intact midbrain, caused by basilar artery occlusion. Lateral medullary syndrome, Wallenberg, caused by pica occlusion. Symptoms include ipsilateral facial numbness, contralateral body numbness, dysphagia, hoarseness, and vertigo. Pearl. In posterior circulation strokes, always assess for cross signs, cranial nerve findings on one side, and motor/sensory deficits on the opposite side. Cerebellar strokes. The cerebellum is supplied by the SCA, AICA, and pica. Clinical features: ataxia, limb or truncal, depending on the lesion, vertigo, and nystagmus. Common in AICA/pica infarcts, and headache and vomiting, often due to edema from a cerebellar infarct, which can cause brainstem compression. Pearl. Acute cerebellar strokes can mimic peripheral vertigo, but are often accompanied by gait instability and nystagmus that does not suppress with visual fixation. To summarize, anterior circulation strokes affect the hemispheres, with cortical signs like aphasia, neglect, or leg-dominant weakness. Posterior circulation strokes involve the brainstem, cerebellum, or occipital lobes, with symptoms like cross signs, vertigo, or visual loss. Remember, localization starts with understanding the vascular territories and pairing them with the patient's symptoms. Practice is key. If you found this video helpful, subscribe for more neurology insights and clinical pearls.